Now, to officially open today's event, it's my honor to introduce Dr. Tham, who is a senior consultant endocrinologist at Woodlands Health, National Healthcare Group of Singapore. She completed her residency in internal medicine and fellowship in endocrine, diabetes and metabolism at the Cleveland Clinic, USA. Dr. Tham has been instrumental in developing obesity services in Singapore General Hospital and played a key role in establishing the Life Centre for Multidisciplinary Care in Chronic Diseases, including obesity. She has a strong interest in obesity management, weight bias, and obesity stigma, contributing extensively to research and global consensus on these topics. Dr. Tham is also the president of Singapore Association for the Study of Obesity, SASO, and holds several leadership roles in regional and global obesity management organizations. She continues to be actively involved in research, education, and influencing both local and international practices in obesity care. So please join me in welcoming Dr. Tham.
Thank you, Dr. Wong, for the very kind introduction. So I'm just really going to do an opening address. My job is just to set the stage for the topic. So I'm representing SASO. SASO is very privileged to work with InnoQuest to bring this CME. So basically, I think I want to come from the angle of MASLD. I'm an endocrinologist, a very basic one. So just how does it relation to MASLD is how obesity comes in. So this slide just talks about what we already know, which is how our obesity rates have really been rising, especially from the 1990s to the 2000s. And some of you may recall that's when our war on diabetes subsequently started, because there were stats to say that if we didn't control obesity, we're going to be very dire in our situation with diabetes, which is therefore very costly, right? So it's always an economics that seems to wake people up. But why is it so that we Singaporeans are really putting on weight? And this is actually from our own data, is the why more than the what, right? So in the sense that we're really, more than half of us are exceeding what we should be taking. We're not moving as much as we did. Perhaps it was COVID. And then obviously with poor mental health, which is a big thing now in terms of the younger people, obesity rates, they may contribute. And when people tend not to smoke also, right? They may resort then to eating. Perhaps cigarettes are more expensive now, but you still can get food at an affordable rate, but a bit that would be the more processed stuff. So this is the stats that was done by our Salisbury Hawk, that if we didn't control obesity rates, we can't control aging, it will really reach very dire straits in terms of diabetes. Right? So I think that's when I mentioned the war on diabetes, stuff like that. So, but we all know that we are all very different, ethnically especially. How we deposit fat, how we react to fat, right? You can see that in the UK, and some of you have seen these slides many, many times. It's just to bring across the point that we as Asians, the lower end, manifest complications, obesity-related complications, and very much lower BMI, and waist circumference, right, compared to our Caucasian or even black counterparts in the world. And that really brings the attention that this is a study, and we never published it, and we did an SGH to show that actually the waist height circumference is very much more related to things like heart disease than just the waist circumference alone or your BMI. So I think in essence, right, MASLD is really a disease of excess adiposity. And this is a very simple slide in a way, complicated but it's very simple. It just says that if we react nicely to excess adiposity, i.e., when our body goes into positive energy, you actually go into a very pro-inflammatory state. But more so than not, we go into the unhealthy state of fat storage in the bottom part. And this is where we start to deposit fat in areas like the liver, the muscle, and even around the heart. And I think today our very topic is on MASLD, right? And it's really not just how much, but how each of us manifest it. And George will go into the prevalence, especially in Singapore. He shared some very, very scary stats with me. And again, this just shows that if we have an unhealthy lifestyle, I don't like the word, but just to coin it, you go into that pink path, right? You go into very pro-inflammatory state, but if you exercise and calorically restrict, you go into actually a better blue state, which is where the brown fat gets activated, whatever brown fat we have left. So I think as GPs, most of you are GPs here, it's very important because you're the ones who see, especially with healthcare SG, you do the health screening, you pick up all these potentially diseases related to obesity, and you can potentially intervene at the forefront, right? So I think you've heard many, many times that if you do need help, we do have programs, and Donna is here, I'm laying our NHG programs here. They are very accessible programs to our populations. They don't have to go further upstream where I belong, and actually we tend to see very, very complicated cases, but if we ever do need help, we also have all the hospitals across the country, including the newest kid on the block, which is Woodlands. We do have obesity-related services to help you. So to end off, I think a lot of general practitioners, in fact, I was one many years ago, we have to deal with so many things, many conditions, right? It's not just what I deal with, is very narrow scope of diseases. We need to upskill ourselves. It's very difficult. So again, I'm going to lay down another program called the Bowline. This is in conjunction with CFPS. It's an online skills course we run every year. It's quite comprehensive. We've got good feedback. So if you like, you can join us here on the weekend of 2nd and 3rd of November. And also join educational programs like Scope. Very nice 30-minute blocks of modules to further upskill ourselves and equip ourselves to manage obesity. So with that, I want to then pass the time back to our chairperson and to all our esteemed speakers, and I really hope you enjoy the afternoon. Thank you so much.
Thank you, Dr. Tham, for that insightful opening. Next, we have our first speaker, Associate Prof. Dr. George Goh, who is a Senior Consultant Gastroenterologist and Hepatologist at Singapore General Hospital, specializing in non-alcoholic fatty liver disease. He completed advanced training at the Cleveland Clinic, USA, and established a metabolic liver clinic in Singapore for managing severe NAFLD. Dr. Goh is also actively involved in international NAFLD research and has published extensively on liver disease and served as a clinical associate professor at Duke NUS Medical School. He is also the chairman of the National Foundation of Digestive Diseases, promoting public awareness of digestive diseases. Please join me in welcoming Prof. Dr. George.
Okay, thanks so much, Raymond, for the very kind introduction. Okay, so my talk today is actually on MASLD and its prevalence in Singapore. But I think I'll probably go a little bit beyond just talking about prevalence and describing the frequency that you see in MASLD, and talk a little bit more about the background between MASLD and what you might have known it earlier on as NAFLD, and then MAFLD, and then now it's MASLD. So why the change in nomenclature, and what's the reason and the justifications for that change? I think it would be nice to have that as a background before we proceed on to talk about MASLD. Then we'll go into the epidemiology and background of this disease, particularly what are the kind of publications or what are the reports that have been done in Singapore, which is in our own backyard. So these are relevant clinical data that is applicable to all of us within Singapore, and sometimes it's also beyond Singapore. So the history of this disease is actually not a new disease. It was first, described a very long time ago by Thomas Edison in the 1800s. And that was the first time where people described fat infiltration in the liver in patients with alcoholic liver disease. Fast forward to the 1970s, and you actually had similar kind of presentations in patients that were also seen in patients who did not take excessive alcohol. And so in 1980, there was this landmark paper that was published by the great pathologist from Mayo Clinic, Professor Ludwig, and he basically coined the term non-alcoholic fatty liver disease and non-alcoholic steatohepatitis. And from there, the kind of nomenclature started about NAFL, non-alcoholic fatty liver disease. And fast forward to that, from there to the 2020, there were a lot of disagreements, discontent with the term non-alcoholic fatty liver disease. So a group of experts, led by experts from Australia, actually came up with the term of metabolic dysfunction associated fatty liver disease. It's quite a mouthful, so I have to have a look. So it's NAFL in place of non-alcoholic fatty liver disease. However, on further discussion with a whole host of other experts, then the term came to be reiterated as MASLD, which is metabolic dysfunction associated steatotic liver disease. So replacing the fatty liver with steatotic liver disease. And so we'll talk a little bit why it is so. So the original non-alcoholic fatty liver disease definition is basically anything that's more than 5% fat in the liver without any other liver disease such as viral hepatitis, alcohol. And the severe form of the disease will be called NASH, which is non-alcoholic steatohepatitis, where there's ongoing inflammation, cellular injury, and these tend to be more aggressive, leading to progression of disease. Then we have the metabolic dysfunction associated fatty liver disease, the MAFL, and this was basically described and defined by steatosis, by biopsy, non-invasive testing or imaging, and just needing one of three metabolic criteria. So if you're obese and overweight, if you have diabetes, that is really a qualifying criteria for MAFL. Or if you did not have any of those, you have lean BMI, but you do have other metabolic abnormalities, two risk factors that will also qualify you for MAFL. Then moving on to MASLD. MASLD is slightly different in the sense that if you have imaging, histology, you only need one cardiometabolic risk factor to be able to diagnose the MASLD. So why has there been so many changes, and what are the nuances and the finer points, defining NAFL, MASLD, and NAFL? So for the original kind of definition, it's basically by exclusion. So you just have fat and no other liver disease, no alcohol, that's non-alcoholic fatty liver disease. If you have, basically for the next reiteration, which is the MAFL, if you have other liver disease, if you have alcohol intake, but you also have a predominant burden of metabolic risk factors, you also qualify for MAFL. So you don't really need to exclude all the other diseases, and it really brings the metabolic kind of problems into the forefront. Then subsequently we have MASLD, where basically you have you can include alcohol, but only to a certain extent, and this will be categorized in another category called metabolic alcoholic liver disease, or MALD, and you can have metabolic risk factors included. That would also be MASLD. So in terms of comparison of the various nomenclature, the MASLD actually adheres more closely with the original because it does exclude alcohol to a certain extent and other chronic liver diseases to a certain extent, whereas the MAFLD does not exclude other chronic liver diseases. So it is a slightly different subset of patients we are talking about. So the criticism of the original nomenclature is because it does not reflect the underlying pathophysiology. It's really a diagnosis of exclusion. So defining a condition by virtue of not being something else is not really a good solution. And the label of a negative prefix, the non kind of prefix, carries a perception that the disease is not really important in the eyes of medical practitioners. And there's also a potential trivialization that was argued for. And further from that, there's also potential stigmatization because there's alcohol in the term, there's fatty in the term, and a lot of people may feel stigmatized by these terms. So this will impact self-esteem, leads to negative health behavior, which actually in a chronic disease like non-alcoholic fatty liver disease is very important to motivate patients to be able to improve their health. Thus, there's this focus on metabolic dysfunction in the new nomenclature. It acknowledges a lot of important contributions of the metabolic burden to the pathogenesis, and it reiterates this disease really as a multisystemic disease that requires holistic and multidisciplinary approach. And that's why it really enhances and recognizes not only hepatologists and gastroenterologists to manage this disease, but many important other stakeholders such as yourself, primary care, the endocrinologists, the cardiologists, the obesity physicians, all play a part. And so this actual nomenclature change really moves the needle forward and aids the understanding, aids the awareness of the disease. So coming to the data, we know that MASLD is everywhere. This data is basically pooled prevalence globally or worldwide, and you can see that it's about 30% worldwide in the adult population, which is quite a lot. And actually, on this slide here, you can see that this trend seems to be increasing over the years. So, we have quite a significant numbers already all over the world, and with an increase in trend over the years, this will become a much sizable problem. If you look at Asia, it's about 30%, slightly less than other countries like Americas, which is 35%, but that means 3 out of 10 of the population have this disease already. So it's quite a significant burden to healthcare systems. So in Asia, we know that the prevalence data is very variable, and that's because it's a very heterogeneous region, and there's variations in ethnicities, in culture, in socio-economic status, lifestyle, living standards. And we must also understand that different parts of Asia have different rates of urbanization and transitioning. And this takes on a much higher implication because in Asia, we already have a high burden of liver disease. So about 62% of liver-related deaths worldwide happen in Asia Pacific, and 72% of global deaths due to liver cancer happen in Asia Pacific. So with this actually makes it more imperative or critical that we know about the most common chronic liver disease, which is MASLD. So what about the data in Singapore? This was one of our early studies that we did in Singapore, and this was a community-based studies where we invited participants to come get an ultrasound, get a questionnaire, and talk about their ideas, attitudes, and kind of risk factors that they have. And interestingly, we found that 40% of these participants who previously were not known to have liver disease were identified with fatty liver disease. And they tend to be consistent with higher male predominance, older age group, higher BMI, waist circumference, and the presence of more metabolic syndrome. The interesting thing we found was that there was lower perception of risk among the public, and there was a disconnect between the perceived risk and actual risk. So although about 70% of patients have actually heard about this fatty liver disease, only 25% felt that they were actually at risk. And of note, about 3/4 of subjects where they had more than one risk factor did not think they were actually at risk. So that really this disconnect speaks to the awareness and the insight of patients or the lack of awareness therefore. So lack of awareness is one thing, then coupled with high prevalence, and then you can see that this is also increasing. And this data comes from another study in Singapore, and this was an SGH surgical cohort data looking at temporal time points of patients who are undergoing cholecystectomies. And they found that over 2 time periods of points, actually the later cohort tend to have higher proportion of patients with fatty liver. So 56% versus 40%, they tend to have higher risk factors like dyslipidemia also. And hypertension, Indian ethnicities was associated with fatty liver disease. Of course, the caveat being the numbers are pretty small in this. So as Kwang has also mentioned, besides obesity, diabetes is a big problem in Asia, and in Singapore, I'm sure many of you are very well aware of the diabetes problem in Singapore. We do know that it has high disease burden, and 60% of all diabetic patients are actually in Asia, and 6 of the top 10 countries with the most number of diabetic patients are actually in Asia. And what we know is diabetes is really a very bad risk factor for fatty liver disease, the aggressive form of fatty liver disease, the steatohepatitis, the progression to fibrosis, and even liver-related events. So this was another study we published. This was done with polyclinic patients with diabetes in Singapore. And we basically recruited these patients to get a fibro scan, which they had not previously done before. So we found that about 80% of all the diabetic patients actually had fatty liver disease. And more concerned, about 13% had advanced fibrosis. Risk factors being AST, platelet count, CAP score, and presence of hypertension. So patients with diabetes are in generally considered high-risk groups, recommended for screening for fatty liver disease. And if you look at some of the recent guidelines from the American Diabetic Association, the family associations, they actually have started recommending or advocating for some form of screening, surveillance of diabetic patients because they are considered high-risk patients for the severe form of fatty liver disease. And then moving forward, we also have another study, which is the Singapore Chinese Health Study. And this is actually quite a long study that has been publishing quite a lot of data about Singapore health. And in this study, we explored the impact of diabetes on cirrhosis mortality. This was a prospective community-based study, about 63,000 patients that were enrolled in the 1990s. So after a median follow-up of about 17 years, about 100 over patients died from cirrhosis. And you can see that diabetes was associated with a 3-fold increase of cirrhosis mortality. And this was still seen in viral hepatitis-related mortality, but the association thesis was much stronger in the non-viral hepatitis mortality. And this group tends to be more the MASLD kind of patients. Then we also have characterized the patients in our tertiary cohort. This is a cohort study that we analyzed in Singapore General Hospital. And so we profile patients according to obesity versus non-obese patients. So the obese patients actually tend to have more metabolic burden. So they had higher prevalence of diabetes, higher obesity, higher dyslipidemia, and hypertension. But when we look at the biopsy results, actually the kind of degree of damage, the kind of frequency and distribution of the NASH was about the same. So both obese and non-obese patients can be equally at risk of the severe fatty liver disease and advanced fibrosis. Then we also have looked at projections, and this was a study that we did in 4 Asian countries, so Hong Kong, Korea, Singapore, Malaysia. And the projections in Singapore do show significant increase of cases, as what was shown before. So about 1.5 to 1.8 million people affected by 2030. And of more concern is the doubling rate of the incident decompensated cirrhosis, liver cancer, liver mortality cases are predicted by 2030. And actually, we are already starting to see that now. So this was another study we published a few years ago, looking at the temporal trends of liver cancer etiology in Singapore from SGH. And while we know that hepatitis B, although still a predominant risk factor for HCC, there was a significant decline over time, whereas the fatty liver etiology was increasing significantly over the same period. And so it is anticipated to kind of replace Hep B as the predominant cause of liver cancer in the years to come. So we have also extended our work and developed Asia network for studying of fatty liver disease. This was the CAP Asia network, which is basically multi-center study, cohort study, look all over Asia. So you have 12 kind of hospitals from Singapore, Hong Kong, China, Korea, Japan, that are looking at this in a longitudinal fashion. And we've been enrolling patients for quite some time already. And so we have described the data on baseline characteristics, and the ongoing data for longitudinal events are still currently being collected. But among the first few papers that we have done is to look at what is the lifestyle habits and physical activity habits among Asians with fatty liver disease. And interestingly, we see that there are some differences. So in China, Taiwan, more patients were smokers. They tend to have more alcohol consumption in Taiwan and Hong Kong. But when it comes to Singapore, somehow we tend to drink a lot of soft drinks. So soft drink consumption is more common in Singapore and Malaysia, and that really is something which needs to change. And if you look at the physical activity kind of guidelines as a whole, only 30% met the guidelines with no differences across regions. So unhealthy lifestyle, physical inactivity are common across all these Asian regions and need to be addressed quite urgently. Then there's another paper that came out from that network, and this is something which I'm sure a lot of you would be interested in. Is basically the suboptimal treatment of dyslipidemia in patients with fatty liver disease. And basically what this study highlights is really that the percentage of patients that are not treated to target or who should be on statins are quite a lot. And these are the ones who are really at the very high risk for cardiovascular disease. So these will need improvement in the years to come. So basically, this is my summary. We do have a high prevalence of MASLD worldwide. It remains important disease in Singapore, and the clinical burden of disease is anticipated to increase in Singapore and in all the other countries around the world. Education and awareness of this MASLD is important for all stakeholders. So not only the hepatologists, the primary care doctors, the obesity management doctors, the patients themselves, needs to have a better education awareness of this disease so that they have insights and they can be more proactive towards it. And in terms of categorizing this disease, it's quite consistent with all the other data around the world. We need to kind of do more in terms of pushing the awareness and trying to identify these patients for screening for better outcome management. Thank you so much for your time.
Thank you so much, Prof. George, for shedding light on the prevalence of MASLD in Singapore. Before we proceed to the next speaker, I just want to remind everyone the food will be available outside until 2:30. So if any one of you would like to go for a second round, please feel free to go ahead. All right. Our next speaker is Associate Professor Dr. Thuhairah, a consultant chemical pathologist at UiTM Hospital. She brings years of experience in managing medical laboratories since 2011, having served as a quality manager and later as a Deputy Dean of Research and Innovation at the Faculty of Medicine until 2023. She continues to contribute significantly to the field of laboratory director in Malaysia and also a visiting consultant in Singapore. And her expertise and leadership has been pivotal in ensuring high standards of diagnostic accuracy and quality in the laboratory she oversees. So please give a warm welcome to Prof. Dr. Thuhairah.
Hi, good afternoon. Thank you very much for that kind introduction. And I think I just should, right? Okay. All right, so my name is Thuhairah. I'm a consulting chemical pathologist, both at UniQuest Pathology as well as the Faculty of Medicine in Hospital Sultan Abdul in Puncak, Malaysia. So I've been asked to pretty much give some updates in terms of what's new with regards to biomarkers I think in Malaysia we're still referring it to MASLD, and I know that Singapore has moved on to MASLD, will be following soon. So in terms of what I'll be touching on is, I think Dr. George, you've pretty much covered it, summarized it really well in terms of why there's this migration, and it does continuously migrate until we get something that's very comprehensive and more accurate in terms of understanding MASLD. So again, I'm not going to go into great detail because Dr. George has already covered this, and it's really just migrating from a diagnosis of exclusion into one of more inclusive when it comes to the migration from NAFLD to MASLD and now to MASLD. And again, this is just highlighting the fact that we're looking at that it's got a better definition in terms of making it more comprehensive, and that we have to also understand that NAFLD is only present when all other causes of fatty livers are excluded, and that does not really give you an accurate depiction because the other liver diseases can be at play with regards to fatty liver. So I think with the new current definition of MASLD, we're more accurately identifying patients, I think, at the healthcare level. So in this particular slide, I just wanted to highlight, I think there was, at one point, the way that cardiologists wants to embrace MASLD and seeing that whether MASLD and MASLD has an association with coronary heart disease. And so this is really just the migration based off the epidemiological studies that have recently come to light, where as cardiologists, I think, just by a short discussion with Dr. George, I think in Singapore, it's pretty much well understood by cardiologists that there is a strong link between MASLD and heart disease. In Malaysia, it's still it's a work in progress, and we're slowly trying to get our cardiologists to understand, to not so much understand, but to adopt this and incorporate this into our local CPG guidelines, that MASLD is a true risk factor for CVD. But from this particular slide, it was pretty much in 2015 when it was first brought up in a statement by the Indian Society, Cardiology Society, where they raised the possibility of having NAFLD at that time having a risk with heart disease. And then somewhere in 2020, there was the migration of the definition, and then in 2022, the AHA declares this, that MASLD is associated with heart disease. So this is, in summary, I think this is not comprehensive, but the most current findings in terms of having that strong link between MASLD and CVD and the cardiovascular risk outcomes. And so you can see that there's been several studies all in line to say that there is a very strong link between heart disease and MASLD. So in terms of early detection, now knowing that you have a very strong risk of CVD when you do have MASLD, that pretty much puts out the need for early detection of MASLD. And one of it is, again, the 40% of Singaporeans having MASLD, and that puts you at risk of CVD, and that 30% of individuals with MASLD will eventually develop NASH, and it also runs its risk of HCC, as well as the complications of liver fibrosis. And then again, treating MASLD is really actionable for the patients as well as for the clinicians, because it can really be reversed if you catch it early. So this was the mainframe of even in Malaysia in terms of the relevance of early detection for MASLD. So this nicely summarizes the various guidelines in terms of how you want to detect or identify those at risk and to diagnose them with MASLD. And you've got the European guidelines and the American guidelines here. And in brief, those who are at risk, and again, depending on the different guidelines, they would define those at risk. And then they would suggest to do non-invasive testing. And this particular diagram summarizes FIT4, which is an established scoring system in most guidelines. So the FIT4 is across the board, and then from there you would detect those at high, intermediate, and high risk, and that will be referred to, and then you'd have the confirmatory testing done. So what I'm planning to focus on is really looking at this second stage, which is looking at the non-invasive testing, and just expand a bit more. So from here, this is the FIT4, and the FIT4 is pretty much simple because it utilizes ALT, AST, platelet, and your age, and it calculates for you your risk. So that's pretty much what's been established in the guidelines. Dr. George, you can correct me if I'm wrong on that. And then this is again highlighting the Asia Pacific guideline, and it's also highlighting the fact that you would want to be doing the NITS, which is a non-invasive, non-invasive testing, and that would be your FIT4, NFS, FibroTest, ELF. So there's a lot of scoring systems, but across all the guidelines, the FIT4 seems to stand out across the board. And then from then on, you would further confirm, and you want to, at which point you want to refer. So for the most part, in general, those at intermediate and high risk would proceed to be referred to the hepatologist. Okay, so this is, I'm sorry that's a bit small print, but just highlighting to you in terms of the existing liver diagnostic options. So you've got, again, what I've just mentioned before, the FIT4, you've got your ultrasound, you've got the FibroScan, biopsy, and liver stat. And these are some of the pros and cons of the respective diagnostic options. In terms of the FIT4, it's cheap, it's easy, the calculation is pretty simple, and you pretty much have that calculation available online. And then, but in terms of the cons, you're going to find that it's not as sensitive and specific. And then it also is very reliant, it varies again with age. So the older age group tends to get false positive. With ultrasound, it's pretty straightforward. It's again non-invasive, and you get the immediate results, but it's operator dependent. And in terms of, again, the diagnostic accuracy, that's also not optimal. And you've got that limitation in assessing the degree of the severity of the MASLD. With FibroScan, it's again non-invasive. You're getting the immediate results, and it can be used for a screening process, and it can also be used to monitor. Again, it's limited whether it's available or not, and whether it can be affected by other factors such as obesity and inflammatory processes within the liver. And it's again operator dependent. So it really depends on how skilled the operator is. In terms of the biopsy, again, this is still the mainstay gold standard in terms of determining the accuracy of diagnosis. But again, it will be invasive now. And it can be a bit expensive in terms of the cost. And again, it's subject to the sampling error by the technician. And of course, you've got the risk of complications. And then you've got what I'll be introducing in a short while would be the liver fast. And that's really in terms of looking, it's again non-invasive. The only difference now between the FIP4 is that liver fast and liver stat is more AI. So this is AI driven based on algorithms and a computer it's a computing language that will incorporate a lot of the biomarkers into it, and then looks at it comprehensively, and then provides the information more holistically. So that's mainly what liver stat is about. The only setback here currently is the fact that it's not widely available in the market. It's not widely used, and therefore, in terms of validation, we do have, for any test, testing platforms that's out in the market, it does have to undergo rigorous validation process, but this is not widely validated clinically. So that's pretty much one of the setbacks that I think as we move along, we would be able to get that sort of data and integrate. So I'll start with the AI approach, and then I'll end my presentation with a particular biomarker for HCC. I'm incorporating the HCC because obviously the complications of MASLD would be HCC, and then just looking at the new biomarker and that particular algorithm. So with liver fast, what it is this is pretty tricky because this is not a biomarker. It's many biomarkers, including anthropometry data that needs to be inputted, and it is actually an AI. It's an AI algorithm. So it has a neural network. So this is the brain or the CPU. And then it gets inputted here, and then it goes into a scoring system based on the SAF, and then it finally churns out the diagnosis. So there's a 3-step-wise computational programming to get to the output, and that's what liver fast is. And so it would require you to incorporate the age, the gender, the BMI, which means that the laboratory would need the weight and height, and then the 10 biomarkers, which I'll highlight in a short while. So this is what it is, and what it pretty much gives you is the indication of the fibrosis, the inflammatory activities, as well as the steatosis rating. And why is it done? It's really mainly so that the patient actually has a non-invasive method of assessment of the liver's health before putting them through the gold standard, which is the biopsy. So that's pretty much trying to avoid the invasive if the liver fast is able to give you an accurate depiction of the liver health. And then what are the biomarkers that's involved? These are the ones, and there are 10 altogether. So and these are the ones that are picked out based off the machine learning. So the ML would have they put in about 13,000 database, and what came up were these 10 that were relevant in terms of determining the liver health. And from there, the machine learns to incorporate this and to come up with a scoring system. So that's beyond laboratory. This is pretty much more of computer engineering. So, but that's in brief what we have understood in terms of how this is analyzed. And so in terms of the reporting template, you're going to see this 3 reporting, which is the steatosis and your inflammatory your fibrosis status, your inflammatory activity status, and your steatosis. And then it will have the final interpretation after incorporating the 3 as one scoring system into one diagnostic interpretation. And so this is pretty much what comes out from all of that they have churned out from these database. So this, with the paper in 2020 that actually established this as the scoring system. So this was the machine learning where they would have developed or they would have trained the system to understand and to make sense of the data. And they had a total of 13,000 data, which later on they narrowed it down to about 2,000, where about 1,000 was done towards the learning of the computer, and the other 1,000 was to the validation. And with the validation of this particular system, it was based off the Clinical Laboratory Standards Institute guidelines. So I think for most of the CAP accredited laboratories, or the mainly the CAP accredited laboratories, they are encouraged to follow the CLSI guidelines for a lot of the method validation and method verification before we put it into use. So they had done this to validate the test. And so this is just another paper in 2021 looking at the long-term prognosis of patients with metabolic dysfunction MASLD by non-invasive methods, and they looked at the FIB4 as well as the liver fast. And what they showed was that both of them correlated quite well, and both of them showed good accuracy in terms of predicting the overall liver-related morbidities and mortality. Okay, so that's liver fast. So we move on to LiverStat. And LiverStat is mainly a screening tool to identify the patients with liver fibrosis as well as steatosis. And what it is that they use 7 biomarkers from the patient's blood and anthropometric data to generate a quantitative fibrosis assessment, as well as to see whether there's a presence of steatosis. And what it is, again, is in terms of the results, it would report as class A to class D. So a class A means that you don't have any liver fibrosis, and there's presumption that there's no steatosis as well. For class B, it's again presuming there's no liver fibrosis, but there might be some steatosis present. And class C and D would be fibrosis, mild to moderate, or presumed liver fibrosis, advanced steatosis, and that's advanced. So this would be the scoring that they have. And this is really, in terms of screening process, it has been shown to be a good tool to screen patients at risk for MASLD. So when you're looking at the LiverStat, what it's looking at is it's looking at these 7 biomarkers along with your BMI, your age, and your gender, and it will computate this and it will churn out the actual results. So the results are pretty patient-friendly in the sense that it will show it's easier to interpret in this case, and it's easier for clinicians to explain because you have them in it's in a diagrammatic representation, and it gives you an interpretation at the end. And you would still have the breakdown of the various results. Now with LiverFast and LiverStat, because we're using the same biomarkers, one of the key challenges within the laboratory whenever we need to adopt these testing platforms is that we need to do a method verification to verify that the claims are accurate by the vendors. So a lot of the time, what's pretty much straightforward is when you're verifying a biomarker, which means that we're measuring it. That's easier for us to do because we've got the CLSI guidelines, and it will give us a standardized statistical analysis procedure to do this for biomarkers. But when it comes to AI, this is the current challenge that laboratory has in terms of how do we now verify something that's AI churn, and we don't really have the formula because obviously it's protected. And so what we have now, the consensus to pretty much verify AI data is to look at it in terms of having it qualitatively verified. So this is so whenever an AI instrument comes into place, we have to do 2 prongs of verification. We already have verification for the respective biomarkers, and now we just need to verify the AI. And when it comes to verifying this, it is really being able to work really well with our clinicians so that I can identify those that are positive cases and those that are negative cases for us to actually do the diagnostic accuracy study. And that's verification at the laboratory standpoint. And so in terms of the results, I can't see, sorry. Okay, in terms of the results, so normally what they would do is they would give you the patient information and you have your results with the scoring and the charts provided with a summary of what the results mean, and you'd have the serum biomarkers, just like in LiverFast. And again, it's scored between A to D, and anything that is intermediate to high risk, the NICE Guidelines UK has come out with a statement for the LiverStat and LiverFast, where if it is in the intermediate and high risk, that that's at the key point where you would want to refer, and anything at the lower risk, then you can actually assess the patients at 3 years interval. And I think for the other guidelines, it's much similar with the FIT4. You would do the 1 to 3 years monitoring for those at risk. Okay. And so this is one of the studies that they have done, and they've shown that there's high negative predictive value for LiverStat, and that it has, I can't read this, sorry. And so that the main key thing is that it has good diagnostic accuracy for LiverStat to actually pick up the patients with liver fibrosis. And so this particular study also has looked at data of 350 patients, and they were looking at the comparing it with LiverStat with the FIT4 score, and it shows that they pretty much had good sensitivity and negative predictive values of LiverStat, and it correlated well with the FIT4. And so the conclusion here was that LiverStat had a higher NPV compared to FIT4 and a lower misclassification compared to FIT4, but both of them correlated in terms of the diagnosis. Okay, so we move on finally to PIVCA2 and the GAAD algorithm. And this is not an AI. The PIVCA is a biomarker, and the GAAD is an actual calculation. So that's the algorithm there. So traditionally, when we're looking at HCC, if we're doing the ultrasound alone, the pickup rate is about 45% for HCC. and it slightly improves with the addition of AFP to about 63%. So there is this unmet need to classify the ones that are not picked up. And so PIVCA came into being, and this is really a protein induced by vitamin K absence or inhibition too. And this is what it is. So what happens is you have got the prothrombin precursor, which is the PIVCA2, and if you have vitamin K, it will form prothrombin. But if you do not have vitamin K and you have a deficiency in that, then you're stuck with PIVCA and it goes up. And a lot of the times with a lot of carboxylation happening in patients with HCC, you will see that they're going to have an accumulation of PIVCA. So two things can actually elevate PIVCA. One is vitamin K deficiency, and the other one is the presence of HCC. And so this particular study had shown when they're comparing PIVCA with AFP, is that PIVCA really detects HCC with a lot higher sensitivity compared to your AFP. And so this is just looking at your AFP alone at 51% and your PIVCA coming in at 86%, and that's detecting all disease. Whereas if you're looking at the early stage, AFP will only pick up around 36%, whereas with PIVCA it's about 78%. And of course with late stage, they're both obviously much elevated, and you can detect them, the cases up to about 64, and for PIVCA it's about 94%. And in terms of the area under the curve, you will see that again, PIVCA also is higher in terms of being more accurate in detecting the HCC. So this is looking at the combination, this is a study looking at the combination of PIVCA2 and AFP, and it shows that combining the two biomarkers has markedly increased the sensitivity. So the sensitivity has increased with that combination in terms of all HCC and in terms of early HCC as well. And you can see that it also has gone up in terms of specificity. And the area under the curve, as you can see, is in terms when you're combining it, it's hitting the 90%, whereas AFP alone is at about 84%. So you can see there's a significant improvement in terms of detection. So with the PIVCA concentration here, what you're seeing here is that your PIVCA concentration really shows the progression of HCC. So in terms of using it for monitoring purposes, this has shown to be the biomarker does show to have quite accurate depiction of progression of the disease. And these are some of the diagnostic performance of PIVCA, and showing that the area under the curve is very much high in terms of identifying HCC, and that the combination of PIVCA and AFP would pretty much increase the detection of HCC. So I think in a way with PIVCA2, we're seeing that it might solve the problem of the tumor marker being that always the problem with it being a screening biomarker, particularly with AFP, because I think with AFP there's a lot of false positivity that we get that's highlighted to us within the laboratory. So if we've got PIVCA on board, that really helps us to pretty much makes the sensitivity and the specificity improve. So the last bit that I'm just wanting to highlight is the GAAD algorithm, and that's derived from the gender, age, AFP, and the PIVCA, the DCP, that's the other name for it. So the GAAP has come about, and this is actually an actual algorithm or calculation where it's an index that's derived from incorporating all this into one calculation, and it will come up with a risk score. And the risk score of 2.57 would be the cutoff to define whether you would pretty much have a high risk of having HCC or not. And so this is, again, the study that has shown that when they have incorporated the GAAP, you can see that for the AFP, the area under the curve is at about 87. When you have PIVCA, it's about the same, and then when you actually have the GAD, it bumps it up to about 95. So the GAD, presumably because you have incorporated the AFP as well as the PIVCA within the calculation, it gives you a more accurate depiction of diagnosing HCC. And this is the STOP HCC MCE study. And what they did was they had 600 over patients, and they divided into those with HCC and those without. And what they have shown was that when you have GAD incorporated, the area under the curve, the ROC, is increased. So you've got a better accuracy in terms of the diagnosis as compared to AFP and PIVCA alone. And again here, GAD can predict the HCC in all disease etiologies, and you'd be able to see that for all disease, cirrhosis, hepatitis, NASH, ALD, and the others, you've pretty much got really good area under the curve for the utilization of GAD. Okay, so this is the current recommendations in terms of using PIVCA, and the main thing that was highlighted, and this is looking at the American guideline, European guideline, the Japan guideline, is these would be the surveillance population that they're suggesting, and the duration of the screening is recommended to be lifelong, and the screening intervals would be 6 monthly. Usually they would have an imaging modality. However, for the Japan Society of Hepatology, you would see that they've already incorporated PIVCA2 within their guidelines. As for the rest, it would still be liver ultrasound and AFP. So I think I would presume the progression eventually would be that PIVCA at some point will be adopted. But this is the current recommendation in terms of the guidelines, and this is again the JSS, the Japan Society of Hepatology guideline that's incorporated the PIVCA2 at the current moment. So I'm not quite sure about the Singapore CPG at some point. I'm not too sure, but the data, the research data looks promising in terms of looking at its diagnostic accuracy. Much better than the AFP that we struggle with within the laboratory. And again, with GAD, the way that we would need to verify if we adopt it within the laboratory is through a two-prong verification. One is verifying the biomarker, and the second would be the verification of the calculation. So I think with that, I thank you, and I guess the questions will be later. Thank you.
Thank you, Dr. Thuhairah, for the detailed discussion on biomarkers and diagnostic screening. Our final speaker for today is Dr. Guan, a consultant in the Department of Gastroenterology and Hepatology at Woodlands Health. Dr. Q, who earned his medical degree from NUS Yong Lin School of Medicine in 2014 and subsequently completed his residency in NUH Singapore. He achieved his MRCP and Masters of Internal Medicine in 2016 and subsequently became a specialist in 2022. Dr. Q has a particular interest in complex liver disorders and general endoscopy. His notable publications include studies on spontaneous bacterial peritonitis, chronic hepatitis B treatment, and the impact of COVID-19 on IBS. He will be presenting an update on the management of MASLD. So please join me in welcoming Dr. Q.
Alright, afternoon everyone. So I'm Guan, one of the hepatologists from Woodlands Health. So today I'll be speaking on the updates in the management of MASLD. Noting that most of us here are actually from the primary healthcare setting, I've actually tweaked my slides a little bit so as to make it a bit more practical for most of us out here. And hopefully the next 30 minutes or so will be something useful and something that you take away from this for your daily clinical practice when you see patients with MASLD. So no disclosures to declare. I think George has previously alluded a lot to about the prevalence of hepatic steatosis in our general population. And this is actually a natural progression of our patients with MASLD. Look at most of us start with a healthy liver, and about 30% patients or so do develop hepatic steatosis initially. And up to close to about 40% of these patients will subsequently develop what we call steatohepatitis, or nowadays we call it MASH, metabolic dysfunction associated steatohepatitis. And of concern, up to a quarter of them may eventually develop cirrhosis and even HCC. And how we partner with our primary healthcare providers is that at the initial stage of the disease, where the patient just have simple steatosis or just a little bit of steatohepatitis without significant fibrosis, this is where the primary care will actually take on a greater role in the management of these patients. And the main aim is to really try to prevent the progression of our patients down this runway into eventually developing cirrhosis and HCC. At the later stage of disease, once patients develop cirrhosis or even HCC, is where patients will generally be managed in the tertiary care setting by a hepatologist. So MASLD is unfortunately a multi-systemic disease. So I joined gastro initially thinking, hey, I can just deal with the liver, the stomach, or the intestine. But hey, no, so this is no longer true. Now we have MASLD. MASLD is not only related with liver-related complications and HCC, it's a very multifaceted disease. It's associated with cardiovascular disease, endocrinopathy such as diabetes, insulin resistance, hypothyroidism, extrahepatic malignancies, CKDs, obstructive sleep apnea, osteoporosis, and psoriasis. So seeing a patient with MASLD is no longer so easy as just dealing with the liver itself. In my clinic itself, when I see a patient with MASLD, these are the spectrum of diseases associated with MASLD that I have to deal with as well. So the top cause of death in MASLD is actually not liver. It's actually the top cause of death is actually cardiovascular disease. I think Dr. Thuhairah has also previously alluded to about the association of cardiovascular disease with MASLD. Number one cause of death, cardiovascular events. Next, follow closely behind extrahepatic malignancies. And only in third place, liver-related events, which boils down to the importance of actually dealing with the cardiovascular risk factors in a lot of our patients to prevent this number one cause of death here. So this is my very broad overview of management of MASLD. So I have broadly classified into number one, we'll talk about weight loss. Number two, cardiovascular risk reduction. Number three, monitoring of progression to fibrosis. And lastly, we may talk a bit about liver-directed therapy. We'll talk about weight loss first. So weight loss, easier said than done, right? So I think a lot of us in the clinic, we have been trying to tell our patients, hey, lose weight. 3 months later, 6 months later, the patient comes back to you, the weight is still about the same. So what can we do? I'll try my best, not the easiest, I would say. So how much weight to lose? Not sure how many of you are familiar with this pyramid. So it really depends on the degree of severity of the underlying liver disease. If you're just looking at reversal of steatosis, just about 3 to 5% or so, we may expect some reversal of their steatosis. If the patients already have got a little bit of inflammation and ballooning of the liver, a weight loss of 5 to 7% is required for reversal of this inflammation and ballooning. For resolution of NASH, typically require about weight loss of 7 to 10%. And if patients already have developed fibrosis itself, typically we will advise a weight loss of at least about 10% for fibrosis regression. And next, and how to lose weight. So we'll go down these algorithms. We'll further describe these different modalities in terms of lifestyle modifications, pharmacotherapy, as well as bariatrics. We talk about lifestyle modifications first. So diet. So we talk about lifestyle weight. So weight is actually a balance of calories in and calories out. So calories in come from drinks, your snacks, your meals, and calories burn come from things like your body function, daily intake, as well as daily activity, as well as exercise. So how I explain to my patients, if you consume more than what you burn, unfortunately, there will be a weight gain. So the trick to is actually really cut down on your calories or ensuring that the balance actually tilt in favor of calories burned. So we talk about diet. So diet, a lot of studies out there have showed that the impact of caloric restriction is important for weight loss. So calorie restriction, typically we aim at net deficit of about 500 kilocalories to about 1,000 kilocalories a day. So if you speak to most of your layman patients out there, hey, you have to cut down on your diet, you have to cut down your calories by 500 kilocalories a day. They'll be like, oh, how much is 500 kilocalories? So as Singaporeans, a lot of us, we love hawker food. And typically I would try to explain to them in terms of hawker food and how much each common hawker food has got how much kilocalories. So typically, if you're looking at your char siu rice or chicken rice or duck rice, about 600 to 700 calories. Most of your noodle-related food, your bak chor mee, your fishball noodles, maybe about 400 to 500 kilocalories. So practically, in the clinic setting, short of referring to a dietitian, sometimes if usually in a very, very packed clinical consult, you tell them to, hey, you have to cut down your diet. Usually I'll tell them to actually cut down on the amount of food that they eat in terms of their meals. So if, let's say you go and eat a plate of chicken rice, really like the chicken, but maybe cut down on the rice. Cut down half the amount of rice, and that will cut down maybe by about 200 to about 300 kilocalories. And if you have bak chor mee for dinner, okay, maybe cut down again on the amount of noodles you have by about half, and that will hopefully add up to about loss of about a negative about 500 kilocalories. So this is a very simple way of how I try to tell my patient to actually cut down on their calories. The other type of diet that has shown a lot of benefit in MASLD is that of Mediterranean diet. So Mediterranean diet is actually a generic term based on actually the traditional eating habits in the countries bordering the Mediterranean Sea. So what is a Mediterranean diet? So it actually consists of mainly plenty of fruits, vegetables, whole grains, potatoes, beans, nuts, and seeds. And olive oil actually forms their primary fat source. And typically when you talk about the poultry, eggs, as well as fish, we advise them to consume in low to moderate amounts. So imagine in the typical Asian context, very, very hard for patients to adhere to such a kind of diet. They may not be, if you ask them to take olive oil, just fruits and vegetables, very, very actually hard. Although out there in the Western population, a lot of the studies on diet has been based on Mediterranean diet and has been shown to be effective in the management of MASLD. The other advice that I usually tell my patients is actually to minimize processed meat, ultra-processed foods and sugar-sweetened beverages. The sugar-sweetened beverages, I tell them, if you need to drink something, drink the good old plain water. And exercise. So exercise will contribute to the calories burned. And most societal guidelines will actually recommend at least about 150 minutes of exercise of moderate intensity a week. And when I tell my patients it is like, Ethan, a doctor, you yourself, do you exercise 150 minutes a week? So unfortunately, most of us may not even exercise 150 minutes a week. Right, but this is important to actually help with the calories burn that I just mentioned in order to be able to lose weight. And some of my patients ask me, So do we do aerobic or anaerobic exercises? Do I go running, jogging, or do I do resistance training, sit-ups and things like that? Actually, the truth is that it doesn't really matter. Both aerobic and resistance exercise have been shown to improve hepatic steatosis. And this is actually a meta-analysis of quite a few papers that compare aerobic versus resistance exercise. And they found actually no differences in the changes in BMI, the ALT level, as well as the changes in intrahepatic lipids. And next, we move on to the pharmaceutical aspects of some pharmacological therapies that we can consider in terms of weight loss. I'm sure many of you are familiar with some of the drugs out here. So over the last few years, GLP-1 agonists has been in the newspapers quite a fair bit. A lot of TikTok influencers, especially in the Western world, they have been injecting themselves with GLP-1 agonists, and they have shown fairly remarkable weight loss, such that there are even like TikTok's crackdown on Ozempic influencers. So we'll probably describe the role of GLP-1 agonists. So how does GLP-1 agonists work actually? So GLP-1 is native to the body and is released from the small intestine after a meal injection. So it's thought to work by reducing blood glucose by inducing insulin secretion through incretin action and reducing glucagon secretion. It has also an effect on delaying gastric emptying and suppressing our appetite, hence helping us to be able to lose weight. However, the native GLP-1 is actually quickly degraded in the body, leading to a short time of action. And that's where the role of synthetic GLP-1 receptor agonist comes in. It has a long 13-hour half-life and has been shown to improve glycemic control and aid in weight loss. So this is one of the very famous papers was just published 3 years ago on the role of subcut semaglutide in patients with non-alcoholic steatohepatitis. And if you look at it, this is actually a randomized control study where they take patients with biopsy-proven NASH ranging from F1 to F3, and they randomize them into a few groups. They randomize them into subcut semaglutide 0.1 milligram a day dose, 0.2 milligram a day dose, as well as 0.4 milligram a day dose. And they compare this with placebo itself. And they found in this study that patients who were randomized to the use of subcut semaglutide, there's a high percentage of the patients with resolution of NASH with no worsening of liver fibrosis, and this ranges from about 36 to 59% in this subcut semaglutide group. And this is just compared to about 70% of the patients who achieve NASH resolution randomized to the placebo arm. But of note, in this study itself, there's no statistically significant difference in terms of improvement in liver fibrosis when they compare patients who are randomized to subcut semaglutide versus placebo. But what's very remarkable from this study is the amount of weight loss that patients managed to achieve with the use of GLP-1 agonists. So if you look at the amount of the body weight loss, patients, they found a dose-dependent effect of subcut semaglutide on weight loss. Patients who were randomized to the placebo arm, just about 1% of weight loss at the end of the study, compared to 5% in the 0.1 milligram group, 9% in the 0.2 milligram group, and of note, in the highest dose of 0.4 milligram a day dose, their body weight, the mean body weight loss is in fact up to about 17%. So, and the next few studies that I'm going to describe also has got very consistent effect of GLP-1 agonists on weight loss as well. So these are two other studies that were just published this year, both in the New England Journal of Medicine, on the role of GLP-1 agonists, again in non-alcoholic steatohepatitis. What a bit different is that instead of GLP-1 agonists, this is tirzepatide. Tirzepatide is actually a dual agonist, so a GIP-1 as well as a GLP-1 receptor agonist. And in this study, again, they randomized patients who have got, again, biopsy-proven NASH to varying doses of tirzepatide. So here we are talking about 5 milligram, 10 milligram, as well as 15 milligram. And again, they compared to placebo. And similar to the subcut semaglutide trial, they showed that actually the percentage of patients who have got resolution of NASH is markedly higher than patients who are randomized to placebo. But again, in this group, in the tirzepatide group of patients, in terms of improvement of fibrosis stage, the results showed that it actually favored the patients who are on tirzepatide, and more than 50% of the patients who were randomized to tirzepatide showed actually an improvement in fibrosis. But unfortunately, this difference itself is not so statistically significant. But you can see actually a trend of the medication being useful in improvement of fibrosis. And this is also one of another trial, suboxetide, again a dual agonist, but this time around is a glucagon receptor as well as a GIP-1 receptor agonist. And again, the studies again favored histological improvement in MASH, with about 40 to 60% of the patients showing histological improvement compared to just 14% in placebo. And they found that the patients who had got a decrease in liver fat content by at least 30% also favored the patients who were on suboxetide. And I think in this tirzepatide group itself, the weight loss of the mean weight loss that patients managed to achieve with a 15 milligram dose was about 15%. So you can see that with the role in using GLP-1 agonist itself, it not only results in more patients being able to it not only results in patients being able to have a resolution of NASH, it also attacks the cardiometabolic milieu in these patients by targeting weight loss and thereby thereby also treating the underlying etiology, which a lot of times is related to obesity. So moving gears, so we have talked about lifestyle modifications, pharmacotherapy, and next, bariatrics. So I see a few bariatric surgeons over here. So this will be interesting because actually among lifestyle modifications, GLP-1 agonists and bariatrics actually has got the largest impact in patients who have got MASLD. So I'll sort of describe. These are the various types of bariatric surgery. So there's gastric sleeve, gastric bypass, gastric bending, or endoscopically. Sometimes you can even perform an intragastric balloons for this patient. And this is one of the largest studies that I found that was just published last year in Lancet on the beneficial effects of bariatric surgeries in the treatment of MASLD. Okay, so this is actually a multi-center study that was performed in Italy last year. I think they recruited, more than 200 plus patients. And in these patients, all patients would have got biopsy-proven NASH as well as fibrosis. And they randomized these patients. One arm goes to lifestyle modification, the other arm goes to gastric balloon gastric bypass, the third arm goes to sleeve gastrectomy. And what's very amazing in this study is that you look at the patients who achieve NASH resolution as well as improvement of at least one stage fibrosis. Patients who actually underwent bariatric surgery itself, more than 50% of them achieve actually NASH resolution compared to just about 20% compared to about 20% of them who were randomized to lifestyle modification. And in terms of improvement of fibrosis itself, this time around, actually there was a statistical significance in improvement in the fibrosis. Patients who underwent bariatric surgery itself, actually a lot of them showed beneficial effects, effects on improvement in fibrosis. And patients who were randomized to a bariatric surgery, when we follow up on their liver enzymes itself, both in terms of the AST and ALT, you can see that patients who had a bariatric surgery, their AST and ALTs also drop at the end of the follow-up as well. And the other thing that's very remarkable about it is that patients who underwent surgery, look at the amount of weight loss that they managed to achieve. Raw gastric bypass, they managed to lose about 30% of their weight. Sleeve gastrectomy about 24% compared to lifestyle modification, just about 5% or so. So if you were to rank lifestyle modification versus a pharmacotherapy versus a bariatric procedure trumps all of them in terms of beneficial effects in terms of weight loss, the NASH resolution, as well as improvement in fibrosis. Right, so this is actually a slide taken from the European guidelines on the management of MASLD, for which we have briefly discussed about the weight loss goals, some of the recommendations to MASLD in terms of diet as well as exercise. Alright, now we'll switch gears. So we have talked about weight loss. Not so easy to achieve, but as much as possible in the clinic, these are things that we usually try to advocate to our patients to try to achieve weight loss in order for management of MASLD. Next, we talk about cardiovascular risk reduction. The reason why cardiovascular risk reduction is so important is that don't forget that the number one cause of death in meso patients is in fact cardiovascular disease. So in terms of cardiovascular risk reduction, we target the main risk factors which are very familiar to most of us here. And we'll be talking about hypertension, lipids, diabetes, and if they are, and to encourage them to quit smoking, stop alcohol drinking. So something that I want to drive home the message today is that statin treatment is safe. So statin treatment is absolutely safe in our patients with meso. So the concerns with statin treatment in meso traditionally has always been a lot of patients with meso has got a bit of abnormal liver function tests, and we see that a lot of physicians may be hesitant to initiate statin treatment, especially when indicated. So statin treatment is actually safe. This is actually a prospective study that they look at, published in Lancet many years ago, so actually 14 years ago. It's a Greece study actually, where they look at patients who already have a cardiovascular event with abnormal liver function tests that they attribute it to perhaps MASLD then. And they randomize these patients to either statin treatment or no statin treatment. So you realize that the patients who have got, who were not on statins, so there was about 200 plus of them, 30% of them or actually develop a recurrent cardiovascular event. Compared to patients who were on statins, only 10% of them develop a recurrent cardiovascular event. And this represents a 68% relative risk reduction. So in other words, patients, if they are not on statin itself, their cardiovascular risk is much higher. And not only that, patients who are on statins, if you refer to the chart up here, the graph up here, patients who are statins, if you were to follow their trend of their liver enzymes, with time, actually the liver enzymes do come down. Compared to patients who are not on statins, actually, in fact, you see a slight uptick, slight increase in the trend of the liver enzymes. And this goes to show that statin treatment in MASLD is absolutely safe in our patients and in fact should be prescribed in patients with a clear indication. And I think also Dr. Thuhairah has also mentioned previously, statins are very underutilized in meso. And patients with detected NAFL were found to be less likely than dyslipidemic patients without NAFL to receive appropriate statin care. And they found that 50% of the NAFL patients with indication to start statin treatment actually do not receive any cholesterol lowering therapy. Okay. I guess a lot of you all may be more familiar than me in this. This is actually the use of it's a guideline on the use of glucose lowering medications in the management of type 2 diabetes. It's actually adapted from the latest ADA guidelines this year. The thing I want to draw your attention to is that the trend of treatment managing diabetes has been moving towards the use of cardiorenal protective drugs, such as GLP-1 receptor agonists, such as SGLT2 inhibitors. So you see GLP-1 receptor agonists, SGLT2 coming up multiple times in this figure right here. So I mentioned quite a fair bit on the potential beneficial effect of GLP-1 receptor agonists in helping with meso. So what about SGLT2 inhibitors? Data of SGLT2 inhibitors in meso, not the strongest, but do have got some benefits in meso. This is a retrospective Korean study where they look at patients who are on SGLT2 inhibitors, thiazolidinediones, PB4 inhibitors, as well as sulfonylurea. And they found that patients who are on SGLT2 inhibitors have a higher rate of NAFL regression. In terms of liver-related outcomes as well, they found that also patients who are on SGLT2 inhibitors had a lower risk of liver-related outcome. Caveat to this is that it's a retrospective study, multiple confounders, but again, if you look at the analysis itself, it may point to a potential benefit effect of SGLT2 in patients with meso. And this is another meta-analysis that look at 10 randomized controlled trials of SGLT2 inhibitors in patients with meso. And they found that patients who are on SGLT2 inhibitors have got a reduction in the levels of the liver enzymes, so in terms of both the ALT, the AST, the liver proton density fat fraction, the visceral fat mass area, as well as the subcutaneous fat areas. So SGLT2 on the whole if you think about it in treatment of patients with diabetes, not only does it have very strong evidence from the cardiology, from the cardiac side point of view, also has got renal protective benefits, and potentially may also have got benefits in MASLD as well. Third point, monitoring of progression to fibrosis. Alright, the reason why we as hepatologists are so concerned about fibrosis and so hard up about fibrosis is that fibrosis actually predicts mortality. And in this meta-analysis, we found that not only fibrosis predicts all-cause mortality, it also predicts liver-related mortality. And the uptick in here is actually patients who have got F2 and above. So any patients with F2 and above, you realize that there's a markedly increase in trend of patients who have got a higher rates of mortality. And briefly, in the earlier presentation, we have talked about FIT4 and the role of non-invasive tests in predicting fibrosis. So FIT4 has been covered previously when we talked about AST, platelets, as well as ALT. So generally, patients who have got FIT4 less than 1.3 can be usually safely managed in the primary care setting, as advanced fibrosis has been excluded. Caveat to this is that FIT4 is not so sensitive in patients who are of elderly age or more than 65 years old. It tends to over-predict and cause a high false positive predictive value, high false positive rates. Hence, actually, in patients who are more than 65 years old, the cutoff is actually revised to 2.0 instead. So the problem with FIT4 is also that there's also a large proportion of patients who may have what we call an indeterminate zone, 1.3 to 2.67, and these patients typically need to be referred to a hepatologist in the tertiary care setting for usually a second-line non-invasive test to confirm or either to actually help to quantify the amount of fibrosis. And potentially, if these patients with fibrosis, advanced fibrosis excluded, can actually be sent back to the primary care for further management. And patients with a FIB of more than 2.67, typically we are concerned about advanced fibrosis. And again, these patients should be referred to a hepatologist. And this is the American guidelines on the clinical pathway for suspicion of fatty liver disease. And things that's highlighted in green is actually where the role of primary care is. So again, we talk about primary risk assessment using FIT4, and the cutoff here we again use 1.3 in patients who are less than 65 years old, and the cutoff we are talking about is 1.3. So last part, liver-directed therapy. So unfortunately, for liver-directed therapy, just this year, finally we have our first ever approved, FDA-approved drug for in the management of MASLD. So just this year, the FDA approved the first drug for fatty liver disease. The drug is called resmetirom, and it's actually priced at USD close to 50,000 a year. So just this year, you would probably take quite some time before this drug ever come to Singapore. It will take and I think right now in terms of liver-directed therapy, at least for practicality's sake, it will probably take another few years. So not anytime soon. So what is resmetirom? So resmetirom is actually a selective and orally active thyroid hormone receptor beta agonist. And they find that in patients, and they find that by express, and hepatocytes actually express a lot of the thyroid hormone receptor beta agonist. And by targeting this THR beta, we found that in the liver itself, there's increase in beta fatty acid oxidation in these patients, and also helps to reduce the steatosis in these patients. So, landmark study published in NEJM just a few months ago on the use of resmetirom, and found that resmetirom was actually superior in NASH resolution, and it improves fibrosis. So again, these are patients. So you realize that in a lot of the NASH trials, a lot of the trials patients, the entry criteria is that the gold standard we have always hold against is always biopsy. So all these patients will have got biopsy-proven NASH, and then with varying stages of fibrosis, these patients are recruited. So same for resmetirom, these are all biopsy-proven NASH patients, F1 to F3, and then randomize them into 3 arms: placebo, resmetirom, as well as resmetirom 80 mg, as well as resmetirom 100 mg. And they found that again in these patients, the percentage of patients who has got NASH resolution ranges from about 25 to about 30% or so, compared to placebo, which about less than only 10% of the patients achieve the primary aim of NASH resolution. And what's very remarkable in this study is also that in this study itself, in terms of fibrosis improvement of more than one stage, if you recall from the earlier studies that I mentioned about GLP-1 agonists, none of the GLP-1 studies has actually met this second endpoint of fibrosis improvement. And resmetirom was the only study that so far met the endpoints of both NASH resolution as well as fibrosis improvement. And the difference itself here, about 25% versus 14% in terms of fibrosis improvement, is statistically significant. And because resmetirom is able to achieve both of these primary endpoints, this led to the accelerated approval of resmetirom in the treatment of MASH right now. So resmetirom is currently indicated for use of for its treatment in patients with MASLD with advanced fibrosis, moderate to advanced fibrosis, F2 to F3. But FDA also caveat that this should be used in conjunction with lifestyle modifications, so meaning diet and exercise, because we also want to target the cardiometabolic value in these patients. And bearing in mind that resmetirom is a liver-directed therapy, it does not affect actually your body weight, okay? But the other thing that it does help is that the study also showed that there's also a significant change in the patient's LDL cholesterol level. The use of resmetirom was associated with up to about 13 to 16% reduction in the patient's LDL levels. So this is the current drug development pipeline in MASLD. Very busy slide, but I think in the next decade or so, we will see a lot. We will see a lot of drugs coming out that may potentially be of benefit in patients with MASLD. So stay tuned. All right. This is all my very last few slides. And this is how I see how we use pharmacotherapy in patients with MASLD. This is the relative contribution of various drugs in MASLD. In the initial stage of disease, we're actually targeting the cardiometabolic value in these patients. We'll be focusing a lot more on the anti-metabolic drugs to try to prevent patients from progressing from just steatosis to cirrhosis. And the role of anti-metabolic drugs by getting them to lose weight will help with the steatosis, will help with the hepatic steatosis of these patients. Once patients develop fibrosis, then that's where the anti-metabolic drugs may not be that useful. And we'll be switching here to talk about anti-inflammatory or anti-fibrotic drugs to try to get patients to hopefully go one stage back, fibrosis regression, and trying to get them to go one stage back as much as possible. So a lot of the research now has been in this pipeline, trying to see whether we can not only achieve NASH resolution, but also fibrosis regression. So this is my summary slide. So I've covered the in terms of management of MASLD, we're talking about number one, weight loss. Weight loss, how do we achieve? Lifestyle modifications, pharmacotherapy, bariatric procedure, cardiovascular risk reduction, targeting diabetes, hypertension, lipids. And again, I want to emphasize that statins is actually safe in a lot of patients with MASLD and is in fact underutilized. So do prescribe statins in our patients with MASLD if they have an appropriate indication of hyperlipidemia. So monitoring of progression to fibrosis with the use of non-invasive tests and liver-directed therapy, maybe in the next 5 to 10 years or so, we may see more liver-directed therapy coming in. All right, thank you.